Thank you. We have a nice small group, so we can make this as informal as you want. I did put together some slides and a short presentation that we can go over. And what I thought I'd do is kind of just give an overview of some of the shoulder conditions that I see in the office and kind of a broad differentiation to know kind of what class of shoulder problem you might have. And then from there, we can drill into certain topics. I wasn't sure if we were going to be dealing more on the arthritis or the sports side, and we're going to kind of just generally cover everything and then go from here. We're going to intersperse some of prevention tips as we go through some of these different disease entities today. We want to turn the lights down a little bit. It might be a little easier to see. Is that too dark? Or is that okay? Too dark. Okay, let's go up from that. It doesn't go halfway on that, or one or the other, huh? All right, let's go the other way then. Yeah, so you can take notes. What do you want to do?
Leave it like this.
Leave it like that? All right. All right. Well, let's try it and see. Okay, so basically, we know where the shoulder is. The shoulder goes between the scapula bone and the humerus bone. The shoulder is a joint, which means it's comprised of the two bones, the humerus and the scapula. It's surrounded by soft tissue, which we call ligaments, and these ligaments go from bone to bone. The ligaments in the shoulder are called the capsule. So this is, you can see my pointer right here, this is the capsule of the shoulder. And this is with everything, all the skin and fat and muscles taken away, right down to the capsular layer right here. You can see the sternum, you can see the ribs, and just to, the heart lies right behind the sternum, the lungs lie deep to the rib cage right here, and then you're going to have a lot of muscles that lie over top. And then interestingly, all of the nerves and blood vessels to the arm come down from the neck, go underneath the clavicle bone right here, the collarbone, come right through here, and then dip right into the arm. So kind of right in the front, right near me, this is where all your major structures are. Yeah. Yeah, we're going to show you that. Don't worry. So this is exactly that. So the rotator cuff. So the correct terminology is rotator cuff. Most people say rotator cup, and I'm not sure why that is, but I have most of my patients say, there's a problem with the cuff, and it's not a cup, it's a cuff, and it's a cuff of tissue that surrounds the shoulder. Okay, so remember, you have your capsule and your ligaments that are deep, and then surrounding that on the outside, your cuff of tissue comprises four muscles, which is your rotator cuff. And the different names of the muscles are here. The subscapularis is in the front. This is looking at the patient from the front, and then this is the posterior view looking from the back. So subscapularis is in the front, and then the common ones that are torn are the supraspinatus, infraspinatus, and teres minor. And where we're going to see the tear is right on the outside where the tendon meets the bone. So I said ligament goes from bone to bone. The tendon goes from muscle to bone. So the muscle of the rotator cuff is here, kind of surrounds the scapula bone, and then as it comes out on top of the shoulder, it becomes a tendon. And that's where we're going to see our tendon tears of the rotator cuff. And here is another picture of the ligaments. And then you can draw your attention to this right here. That's your biceps tendon. Okay, that's your biceps tendon, which actually starts inside the shoulder and then comes out and then comes down the front of the arm here. Here are the ligaments that are on the inside or on the socket part. And then there's the biceps right here. So a lot of times when you have shoulder pain, it can be your biceps tendon, which actually the long head of it starts inside the shoulder. So the history that I would take in the office, we look at the age, and the age is going to split as to what kind of pathology is happening. Is it their dominant side? Is it a work or a sport activity? Where, when, how bad is it? Does it radiate down? Because usually nerve pain is the pain that travels down, and what makes it worse or better. The pathology, the different categories, the acromioclavicular joint sprain is something we see in young athletic individuals, and then later on we'll go into arthritis. The rotator cuff, either tears, partial tears, or tendinitis. A variant of that is called impingement. Instability, we see that in the younger athletes where the bone moves a lot around inside the shoulder, and then shoulder arthritis. So a quick reference to know what type of problem you have. Instability, these are usually young adults, females under the age of 30. Impingement rotator cuff tear, usually over 40. So you're not going to see a 20-year-old kid come in with a rotator cuff tear. That's extremely rare. Okay? Arthritis, over 50, and then a frozen shoulder, that's a lot of times related to diabetes, and it's greater in women than men, and it's kind of in that 40 to 50, 60-year-old age range. The inspection, we go in, first thing is properly disrobed. I mean, that's something in this time of medicine, as everyone's getting these office visits quicker and quicker, it is important to be able to see the whole shoulder. So when you come to the office, we'll have you put a gown on, and that way we can bring it down. We can see the clavicle, we can see the shoulder, we can see the scapula in the back. I think that's important to see the one side versus the other, and that goes into asymmetry. Scars, ecchymosis, if there's a recent injury. Then we're going to do some palpation. We're going to palpate over the biceps, the lateral humerus, the scapula, and the acromioclavicular joint. Ruled out referred pain, I mentioned this earlier in terms of the nerve pain. I think one of the hardest things is to differentiate when someone comes in with a shoulder pain, is it coming from their neck and it's a pinched nerve, or is it intrinsic to the shoulder itself, meaning rotator cuff or arthritis or something else? They can present very, very similar. One thing I find is that pain usually goes down. So like for carpal tunnel, which is a pinching of the nerve in the wrist, that goes into the hand. Rarely will it go up to the shoulder. Shoulder pain usually presents itself in the mid portion of the humerus, like right here. Shoulder or mid portion of the humerus, rarely below the elbow. If it's your neck, it's going to be up in here, and the big spot's going to be up in this trapezial muscle, which goes into a lot of spasm and comes over the top of the shoulder. So a lot of times people will be on my schedule, they'll say shoulder pain. First thing they say is, doc, the pain starts right here and shoots right down my arm. Most likely that's coming from their neck. So that could be a herniated cervical disc, stenosis, which is a tightening of the canal, which can cause pressure on the nerves, a strain if there's some sort of trauma, and then the fracture as well. And this is just an MRI picture of someone's neck. I don't know if that shows up great, but you can see right in this area, they have some degeneration, which is causing the cervical spine to be pitched. That would be arthritis. That would be arthritis. We want to check the range of motion, and we're going to check that actively and passively. Active is what you can do. Passively is what I can do. So if you and I can't get your arm all the way up, then that's probably a frozen shoulder. If I can do it and you can't, that might be a rotator cuff tear, because you just can't initiate enough motion to get it up in the air. So here's an example of how we test for the rotator cuff. This top one tests the supraspinatus, which is the muscle on top, and then this external rotation by pushing against it. This is the muscle that's kind of on the back side, the infraspinatus, and these are the two most common ones that are torn. The subscapularis, that's pretty rare, but like in an older gentleman that has a fall might have a massive rotator cuff tear where they tear the whole thing off, and the subscapularis will be involved, and that's usually a slightly more extensive surgery, and these are just two tests we do, the lift off and the belly press, to see if the subscapularis is torn as well. The AC joint, and a lot of times these AC joint pain goes hand in hand with the rotator cuff. But you follow the clavicle all the way out to the end where it meets the scapula, and they're tender over this area. And then especially in like weightlifters, we'll see this a lot. They have pain as the arm is moved across the body. Here's an example of a shoulder separation. So this is a common one where it's not actually your shoulder joint that dislocates. That's a separate condition. A shoulder separation, like the hockey player that gets banged against the glass, the person that falls off their bicycle, let's say, this bone should be down. I don't know if you can see that much at all, but this bone should be in line with this. And instead it's popped way up. And that's when you see the people that have the big bump sticking up right here. So that's a AC separation, usually in the younger individual. And there's just a clinical. Can you guys see that at all? I don't know if it's hard from where I am, but quick picture of that. That's an AC separation, and you can see, wow, that's the clavicle that's sticking way back up on there. So that might be somebody that needs to have surgery to fix that down. Okay. So shoulder instability. This is in your young individual. This is in your female, and this is this lady here hanging from the rock. This is a potential problem where you stretch out that capsule, which are those deep tissues in the shoulder. So here's just another example of someone who can really bend their arm back, and that's something we see in the office. Believe it or not, people have different. Their collagen. Some people's collagen, which is the fibers that make up the ligaments, they stretch more than others, and you can get this kind of condition. And you can just see that having that loose tissue can lead to sprains and tears, and even fractures because your arm's in a position that it shouldn't be in. Again, these are some tests we do in the office for shoulder instability in the younger individual to see how loose they are. If people have shoulder instability, usually it's physical therapy to retrain their muscles to strengthen the shoulder. If that all of the physical therapy doesn't work, usually after 6 months, we can go in and actually tighten the capsule so they're not loose. Here's just an imaging, and this X-ray right here, this is the humerus, this is the scapula, the part of the scapula called the glenoid, and this is slipping right out because it's so lax. Shoulder dislocation, that's when the ball comes out of the socket, and we see this. If it's young, you usually have a lax capsule, or you tear some of the ligaments. If you're over 40, you can tear your rotator cuff. So we'll get called down to the emergency room. 65-year-old female fell, and her shoulder's out of position. Well, we'll give her medication, anesthesia, get the shoulder back into position, but then we'll have to get an MRI and likely have to fix the rotator cuff. Okay, because if we don't fix that, then she'll go on to have a problem. The dislocation in the young person, a lot of times we can rehab them depending on what their activity is. Some people are actually advocating in the younger patient, depending on their occupation or sport, to get them fixed sooner. And this is just an example because a lot of what we can do now is through the camera, which is pretty neat, the arthroscope. And this is just a view of someone's shoulder where you can see the torn ligament kind of bunched up right down here. This being the humeral head, and then this being the glenoid on the other side. Impingement syndrome. So for me, I think impingement syndrome is like rotator cuff tendonitis, and this is probably the most common entity in the shoulder that I see in the office. And the rotator cuff, so this is not just air in here, this is where that rotator cuff, the supraspinatus, sits. It goes underneath the acromion, or this part of the scapula, and then goes on top of the humerus right here. And that constant friction as you bring your arm out, it can rub and pinch between these two surfaces and get irritated and partially tear and then fully tear. There's a bursa, which is a potential sac of fluid, which lives in this area right here. So a lot of times when the tendon gets irritated, the bursa gets irritated. So we call that bursitis, tendonitis, impingement. All those three things are the same entity to me. And a lot of times we can calm it down with an anti-inflammatory, we can do some ice, we can do some stretching. And if that doesn't work, sometimes an injection of cortisone is enough to bring the inflammation down. And then usually just some physical therapy strengthening to retrain some of the muscles to keep that from getting irritated. And I said earlier, the rotator cuffs are rare in those under 35. The impingement syndrome, and it can be the repetitive overhead activity. These are the athletes that are throwers doing tennis, swimming, or laborers overhead. And a lot of times it's just time. I mean, 15 years of doing the same activity can cause the irritation. Here's just an example of how close sometimes that bone is to that acromion. If we ever get to the point where there's surgery needed, if the cortisone doesn't work, we'll go in, we'll clean everything up, shave out all the inflammatory tissue, and we'll actually shave some of this bone out. And the reason we'll do that is we'll give it more space for that shoulder to move up and down. Okay? Usually not for this impingement. Usually the shoulder bothers you at night. You can't lie on that side. The pain starts in the shoulder, comes down to the deltoid insertion, which is on the mid portion of the arm. Diagnosis here. Here's some tests to show that, to get the humerus in a position where it's underneath the acromion, and then that pinching sensation. And really, this elicits a pretty powerful pain response. So people are not happy with you when you do this, but very quickly you can determine the etiology of the problem. So here's just an example of giving an injection. And this is what we call the impingement test. So if they have impingement or just irritation, let's call it that, or tendinitis, and we give a injection of Novocaine, and I'll also combine it with some cortisone just so you have to get one stick, and then we'll wait about 5 or 10 minutes, come back and examine again. If your pain's gone, then you got it. But if the pain is still there or their arm is still very weak, then I'm thinking we didn't get it. It's more substantial. It might be a rotator cuff tear, and then we'll go ahead and order an MRI for you to see if we can make that diagnosis. If you have a big rotator cuff, there's no sense doing numerous injections, months of physical therapy. It's time and money when, for certain people, a surgery is going to be what's needed. The treatment is the nonsteroidals. That's like your Advil, Aleve, your strengthening of your rotator cuff, injection. Some people will do up to 3. And then if all that fails, then we can go in with the camera and the shaver, just through a couple little poke holes and clean everything up. And then afterwards is another month or 2 of physical therapy. So here's the rotator cuff tears. You probably all have friends that have had a rotator cuff or had surgery for a rotator cuff. And I'll tell you, the surgery is not so bad. Maybe for a day or 2 afterwards, but it's the physical therapy and that process which is really long. So it's not uncommon, and there's no cheating it. It's 4 to 6 months of physical therapy afterwards, which is really a really long time after rotator cuff repair. Partial thickness versus full thickness. The question is, if someone has a partial thickness tear, do they need surgery? And I think it goes by symptoms. I think if you've done everything else and they still have pain, a partial thickness tear will do very well by going in and cleaning the tear. Basically what we do, if it's partially torn, we'll go in and complete the tear. We'll basically just cut the rest off, clean everything up, and then sew it back as a whole. And times that I think that I haven't served patients well are when I think they just had impingement or a little partial thickness tear, and I didn't do anything with the rotator cuff tear, and then 3-4 months after surgery, they still have pain, then we have to go back and do a second procedure, which is not what people want, especially because of the long amount of physical therapy and the disability from 2 procedures. But here's an example of someone with a massive rotator cuff. They can't lift their arm. You need your rotator cuff to pull the head into the socket and to initiate the arm being raised. So if you don't have a rotator cuff, you can cheat and kind of swing your arm up, and then once you do that, your deltoid takes over and can bring your arm over your head. But here's someone in the office, we just ask him to bring his arm up, and it's almost like a paralytic arm where he just can't get up past that first 30 degrees, so he can't get his arm up. And then here I said the difference between active and passive range of motion. Active is what he can do, not much. But on someone like this, passively, if he relaxes and I take his arm, I'm able to move it in all positions. So he doesn't have a frozen shoulder. He has a rotator cuff tear. Injection test is another one. Is he limited just because of pain? And this is interesting because sometimes I'll see people, they say, I can't move my arm. I say, well, how long's it been going on? 2 days. What happened? Did you fall down a flight of stairs? No, I just woke up and I can't move my arm. And they're honestly being truthful with you because the pain is so bad that they can't initiate that rotator cuff. But a way to check that is with that injection of Novocaine. Once that area is anesthetized, then all of a sudden they say, "Oh my God, doc, you're great," and they can move their arm again. And again, that Novocaine's going to wear off in a few hours, but you know that there's more of an impingement than a tendon tear. Just another example of testing that muscle. And then here is the MRI, okay? And the MRI does not use X-ray, so there's no harm in getting an MRI. I think the hardest thing for some patients is you have to go in the tube. We have an open MRI, which is a little bit larger, but you still have to go in the tube. Some people need a little sedative before they go in and have the procedure done. Ideally, we like the closed over the open just because the pictures are a little bit better. And if you're not sure about the diagnosis, the pictures can really make a big difference between deciding, yeah, this person needs surgery or no, they don't. And then we can look at the tendon tissue. From this, we can see if it's a new tear or if it's an old tear. We can see how much atrophy there is in the muscle. We can see how far back it's retracted. Someone might come into you with a week of shoulder symptoms, and you go in and their MRI shows that they tore their rotator cuff 5 years ago. So that might be one that's not even fixable. We can also assess arthritis, because if you have a lot of arthritis in your shoulder and a rotator cuff tear, you might not do well if you just have a rotator cuff repair, because now you're going to have arthritic symptoms. So that's someone that might get a different operation. The treatment, I think if there's a full tear, most people now will advocate for surgery. So the physical therapy, that's PT role, is to restore the range of motion. And I always say that, you're not going to get more motion after the surgery than what you have before. You might be able to do it better on your own, but if you come in and your arm only goes up 70 degrees or so, and then you have surgery, it's going to cause an inflammatory response, and you're not going to get that motion back. So you might spend a couple months getting your motion back first before surgery, and then we'll continue with the physical therapy afterwards to keep it. If you have a small tear, small tears tend to become large tears. And as surgeons, we do better when the tears are small. So that advocates to saying, hey, look, you have a small tear, you're active, you like to play tennis, you like to do things overhead. You might want to go ahead and just fix this small tear, because once it becomes a large tear and you're really symptomatic, then surgery doesn't do as well. Now, glenohumeral arthritis or arthritis of the shoulder, a lot of people come and say, I have a rotator cuff tear, and actually you don't, you have arthritis, okay? It's less common than in your hip or in your knee, because it's not a weight-bearing joint. Some of the things that we see are some crepitus, which is kind of a sound that the shoulder makes on the range of motion, and that's the two bone edges rubbing against each other, or a limited range of motion. And the big one is this. People with impingement or tendonitis have a hard time doing this. People with arthritis can't go back that way. So that's a good way to kind of differentiate in the 55-year-old, is it arthritis or is it a rotator cuff? So not everybody that has a bad x-ray needs surgery. So I said up here, who has pain, who do you treat, how do you treat them, and what are their expectations? And some of these people will have an awful looking shoulder, but be minimally symptomatic, like this guy on the top here. He has bone on bone arthritis. This is a huge bone spur right here, but he can get his arm up over his head. And then this guy down here also has severe arthritis. He's got a big cyst, which sometimes we see with arthritis, and he can't raise his arm. So you have to talk to people and what they want to do before embarking on a treatment plan. And I'll tell you, if you have a shoulder replacement, which is the treatment for arthritis, kind of like in the hip or the knee, you have to be careful, and you might have to change your occupation. If you're really, let's say you're an iron worker, you're not going to be able to do that overhead work, or that shoulder replacement's going to wear out over time. Here's a total shoulder replacement, kind of like if we talk about a total hip replacement or a total knee replacement. And what we mean by that is we're fixing on both sides of the joint. That's as opposed to a hemi-arthroplasty or half a replacement. We do those for hip fractures, but usually when you have arthritis, we have to work on both sides. So bone on bone here, total shoulder, and the total shoulder on the scapula side is plastic. So that's why you don't see this piece of metal. This is the metal right here. Okay. So the metal has a lot of iron in it, which is very dense, and that's why it shows up white on an X-ray. So total shoulder is the treatment. Now, more recently, we've been doing something called a reverse shoulder replacement. You guys have probably heard about that. That's the next step up. That's the latest and greatest. Who gets a reverse shoulder replacement is if you have arthritis and you have a rotator cuff tear, because you need your rotator cuff to, like we said before, to kind of keep the ball in the socket. And if you don't have that and we do a shoulder replacement, you're not going to move your arm very well. So if you have a massive rotator cuff tear and arthritis, you get a reverse shoulder replacement. And what we mean by reverse is we change the anatomy and we put the ball on the scapula side or the socket side, and we put the concavity over here. And the reason we do that is because it then holds the two things together, and then it just allows the deltoid, or the big muscle in the front of the shoulder, to move it. So reverse shoulder replacement comes into play when you have arthritis and you have a rotator cuff tear. Still the same surgery, still the same, 1 night in the hospital, still the same recovery time of 3 to 4 months, but just a little bit different in the surgical technique. So slap lesion, this is more in your 20-year-old baseball player. This is part, when we talked about the biceps being inside the shoulder, this is part of the capsule here that tears off. And sometimes, depending on your activity level and your sport, this needs to be tacked down. So here's just an example of a guy who's a water skier coming down in this area, and he sustained a slap lesion. Just another way to test for it. A lot of times it can be confused with rotator cuff pathology, but an MRI, and what we do is an MRI arthrogram, where we actually inject dye in your shoulder and then do the MRI. That's better when we're looking at a slap lesion. And here's just the picture inside the shoulder of somebody that has the torn tissue that comes off the bone. Biceps rupture. Here's just an example of a gymnast that ruptured both biceps, and you can see the indentation right here. The biceps, bi meaning two, has a long head, which is in the shoulder, and a short head, which is outside. So if you lose your long head, you don't change any strength in your arm, you just get a cosmetic deformity. So I'll see this in the guys that are really pumping it out at the gym. They're, especially if they're doing the steroids to enhance their muscle mass, they will have tendon degeneration and pop their biceps. So they'll have a cosmetic deficit. And I'll tell them, hey, there's no functional problem. You'll still be able to lift as much as you want. But a lot of these guys are very vain, or they're competing in shows, and they'll want their biceps tendon tacked back down to keep as much symmetry as possible. But here's a guy where both of them were ruptured. Distal biceps, it has two when it starts and only one when it finishes. So the distal biceps in a younger person we usually fix. If you don't fix it, you lose about 30% of your ability to turn your hand up in the air, what we call supination, and about 10% of your flexion strength. Most people that are 35 aren't willing to accept that. Somebody 65, then it can kind of go either way. I have a guy that's 59 years old that actually did it moving a refrigerator, and he's on the schedule for Friday. He said, I just want to have it fixed. I don't want to have any limitations. But as I told him, there are some risks with surgery. So we went through that, and he's still going to go ahead and have that fixed. The pop, the tear, the bruising, the Popeye deformity, and then that's what we talked about. And if surgery is needed, the earlier the better. And the reason being is because once that tendon loses the tension, it curls back up into the arm, and it can make it hard to pull it all the way back down and fix it. And this is the other one, the frozen shoulder we see in the diabetics. And this is the irritation that we see in the capsule, is kind of the red injected appearance. We can inject that with cortisone to calm that down, and then a lot of physical therapy, the passive manipulation to get the mobility back. It does come, but it does take time, and it is painful in physical therapy. But usually people get better with that. Occasionally we'll go in there again with the camera, and we'll actually burn through some of the scar tissue or some of the capsule in order for them to move their shoulder. And here's just an example of the wand inside there that we use to burn the tissue to release it. So prevention of some of these shoulder problems, I think a lot of this depends on how old you are, your activities. and what disease entity you have. And a lot of these things are common sense, but they make sense, and it's amazing if we do these things, how many of the problems down the line I will not see. But a lot of times people are careless, they overdo it, they can't take time off from work, they're rushing to get a job done, and these things happen. So they really do make a difference in terms of stretching and range of motion exercises for your arms and shoulders to keep things limber. You don't want to be stiff and then all of a sudden reach up for something in the top of the cabinet can cause an irritation or a tendonitis. The good posture to take the pressure off of the shoulders, the warming up well and stretching before the activity. Um, and I laugh about this, and this extrapolates a little bit, but I was playing basketball, and now in my 40s or whatever, but playing with some younger kids, and you don't stretch, you don't warm up, you're like primed for an Achilles tendon rupture, patella tendon rupture. I mean, that's the age that I'm in, so it really makes a difference to do that. The protective gear, seatbelt. I mean, that's just common sense. That has to be done. The alcohol and drugs. I mean, this is not the audience for that, but a lot of the stuff we'll see in the emergency room is alcohol or drug dependent. Catching falling objects. Don't be a hero. The step stool, so you're not reaching overhead with a heavy object. Um, the repeated arm movements. I mean, that makes a difference. We see the occupational injuries, and we've advocated out in the community that they take a 5-minute break every couple hours. I mean, people that are assembly line workers will do the same thing every day, and it's no wonder after 15 years they start to get some irritation and problems. Keeping your arms out to the side or raised overhead, especially if you're doing house projects, that makes sense. And then when we have rice here, the common things to do when you have a tendonitis or early irritation, being the rest, stop that activity. Don't say, oh, I just wanted to power through and finish up my landscaping project, because, that will bode well for a problem. Ice is great, and I tell people no more than 20 minutes at a time. And the reasons for that is because it can damage the nerves that are underneath. They did a study on that in the knee, and some of the nerves are more superficial in the knee, and you don't want to go and irritate the nerve as much as it won't come back. So that's why we say icing for no more than 20 minutes. Acutely irritation, you're going to use ice, and down the line, if you're stiff, that's when you use heat. So I'll tell most people ice, the time to use heat is before you are going to do an activity, like to warm up, or first thing in the morning if you're very stiff. Sometimes that hot shower is enough to loosen things up. Compression, that makes it feel better. I think it tricks your body a little bit because you feel the compression and not necessarily the irritation. And elevation is always good to prevent swelling. Sports training specialist, I mean, that's great. The child's backpack, we could see a lot of shoulder and back and neck issues from that. You'll see the kids with the rolling backpacks now. And then the workplace things, sometimes you have to speak up and say, hey, look, I think doing this repetitively is a problem, and some modifications are needed. Make your home safe. You can go online and find some of these things. Healthy foods, I mean, it does make a difference. I mean, the people that do not eat well, fast food junkies, they are much more likely to have this stuff down the line. So eating healthy food makes a difference. Exercise and staying active, begin slowly. I mean, that can't be overemphasized. I read one study in terms of people who, they're working, now they retired, they go to a gym. I mean, my mother-in-law, she said, okay, she worked, retired, and said, okay, now I'm going to go get in shape. And within 3 months, she had a stress fracture in her hip because she went and she just did it every day, went with that same intensity. It doesn't work that way. We know runners, within 6 months, 50% of them will be injured because they don't start slowly. The alcohol drinks, you just got to watch it because, if you're impaired, you're more likely to fall or have a problem. And then also both alcohol and tobacco are related to osteoporosis, which weakens the bones and can set you up for more likelihood of a